ready, Scott? You ready, Scotty?
I'm ready, brother. Let's get it going.
Okay, everybody. Welcome back to Your Crisis Coach with me, Fred Carroll, and Scott H. Silverman. Today, he brought a friend with him, his friend Luke. Hi, Luke.
Hi, how are you?
I'm well. Everything's going good with you, as we heard in the pre-show. Your life is going grand and smoothly.
Smooth as peanut butter.
Smooth. So, since you were talking about that, you said you felt guilty.
I did.
Now, what can you describe the scenario more? Where
Sure. Absolutely.
What happened?
Well, before going into the field of behavioral health, and I'm now I'm the director of behavioral health for the County of San Diego. I've got quite a bureaucratic position. Before becoming a bureaucrat overseeing this massive bureaucracy, I was a carpenter, and I spent about 5 years really sort of focusing on carpentry between undergraduate and graduate school. And I still find it one of the most therapeutic things that I can do to just sort of like help me manage the wackiness of my life, which involves running a psych hospital and a bunch of behavioral health services and a massive network because I'm the Medicaid payer out here. And one of my more recent carpenterial efforts was building monkey bars for my 6-year-old daughter. And I was extremely proud of these monkey bars built with poplar railing, just gorgeous, about 6 feet off the ground. And in the waning moments of the last daylight of her summer vacation, in the warm, soft, crepuscular light, she ate it off the monkey bars and broke both her radius and ulna on her non-dominant hand. So anyway, and I feel guilty because I built the damn monkey bars.
Well, it is what it is at this point. Kids get hurt. That's what they do.
That's what people...
And she's doing fine today. She had a good day at school.
She was happy with the drop off because people were moths.
There's pity. There's
moths
pity involved.
Oh my God, she's got a big pink cat. She looks like a Civil War veteran with pink.
Well, good. Now that we got that out of the way, let's explain to people who you are exactly and why you're here. What do you do that has to do with the addiction recovery and mental health?
Yeah, thank you. I was starting to say some of this before. So I am the director of the Behavioral Health Services Department for the County of San Diego, and in the state of California, county local governments run the behavioral health service networks for people who are on public insurance, on what in the state of California we call Medi-Cal, but is Medicaid as a federal program, and there are very particular eligibility requirements for that kind of what we call specialty care system within California counties. So you either have to be enrolled in Medi-Cal and have a serious mental illness or any substance use disorder. So substance use disorder, of course, with the most recent DSM is framed as a spectrum disorder, right? Mild, moderate, and severe. But county behavioral health service departments and plans in the state of California have we are the health plan for everyone on Medi-Cal with any substance use disorder at all. And then again, on the mental health side for people with serious mental illness. So it's a lot, just to say, right? I mean, this is a county of 3.5 million people, and about a third of those people are on public insurance, which is, I think, quite an alarming statistic. People don't think about places like San Diego, which of course is known for its, resplendent wealth. I mean, it's known at this point for being an unaffordable place for lots of people because housing values have gone so skyrocket, and wages have not followed suit necessarily down here. And that's actually only increased the rolls of people on Medi-Cal. So we have around 1 million people in this county who are on public insurance. Substance use disorder is, and this is a problematically underappreciated thing, right? It is like the most common chronic illness that that any community faces, frankly, in the United States. Certainly, that's true of San Diego as well, right? I mean, the rates, the population health rates of people who are diagnosable with substance use disorder is, we estimate between 16 and 20%, right? Very high. Compare that to something like type 2 diabetes, it's like 7 or 8% in a place like San Diego County. Now, type 2 diabetes is, of course, thought of as this incredibly common chronic illness. It's very normalized, right? People don't carry a stigma around so much because they've got type 2 diabetes. Maybe they take some flack for what their diets might have been or what their diets should be, et cetera, et cetera. But there is, I would say, overridingly a sense of normalness about type 2 diabetes and the extension of sympathy for people who struggle with it. And, and as a kind of, as a significant condition, just seen through the lens of prevalence, it is wildly superseded by substance use disorder. And so just to say, there's a lot going on in this department because so many people are struggling with substance use disorder, and so many people are at risk of substance use disorder. So, like, as the thing that is meant to be like the payer, the health plan, for 1 million people, a significant percentage of whom are likely to have substance use disorder, it's very preoccupying for me. It's a huge part of it. It's a huge part of it here, though, of course, the scope is broader. And frankly, issues around serious mental illness tend to get much more attention than substance use disorder. I think that, you see reflected in that to some extent. What I think is fairly understood is the greater stigma associated with substance use disorder, with addiction and with mental illness. And just sort of like the shape of current politics in California, which is very preoccupied with homelessness and kind of therefore very preoccupied with psychotic disorder among people who are experiencing homelessness, because that's like the most sort of difficult to manage and conspicuous image of homelessness that so many people in the state of California encounter is, an obviously unsheltered person sitting on the street telling any passerby that, that they're, Jesus, Joseph, and Mary all at the same time, right? I mean, that's kind of the sort of stereotypical notion. But it's also one that's fed by a lot of political actors, right? There is a lot in the sort of discourse right now in California that overemphasizes the significance of behavioral health and serious mental illness in particular as a thing that causes homelessness, which we know from data is not true. Nor is it true that substance use disorder causes homelessness at the population health. But there's a lot that motivates that narrative, and I would just say it's leading, I think, or has led to serious mental illness getting, to some extent, disproportionate attention. So yeah, that's at least an introduction to points of engagement I have with stuff that you're interested in.
Yeah, that's very good. What do you got for him, Scott? I know you're dying to ask something.
Yeah, well, first of all, Luke, you make me stutter. You articulate a catastrophic responsibility in such a soft way. I mean, in especially in a city like San Diego, where we're part of the big problems in California,
yeah.
And plus we're a border town, so we have all kinds of people. I call them virtual snipers who are just waiting for someone to step out of line or misspeak, or and I've been pulled back into this homeless arena in a big way, and I can say things you can't. Well, you could say them, but you have a much bigger hierarchy that you have to respond to, but a lot of the providers they're in trouble now, and and watching the governor go to Los Angeles and help pack up tents and put them in trash trucks, I'm not sure that's going to help anybody. So what I would like to ask you, because I think it's something we talk about a lot, is if you had because I know Fred's got a bunch of questions, and I got a couple of that people, when they heard I was going to be talking to you, they go, "Can I come on the show?" And I go, "Well, if your attitude wasn't so vicious, we might invite you as a guest. But why don't you just go ahead and email me?" So if you had a magic wand, and and I don't know if you shared it, but I know you've shared it publicly before. You have $1 billion budget, and one would think if somebody has $1 billion, gosh, they could do a lot. But we've just seen the governor share that we've spent $25 billion or $24 billion in California the last 5 years. So that means we're spending $5 billion a year. And in my opinion, the problem is getting worse. So is spending more money going to solve the problem? And my attitude is, I don't think so, because if the same people do the same thing, the same problem, and aren't making inroads, then, are we really helping fix the problem? So the question back to you is, if you had a magic wand, as somebody who has, been on both coasts and been in big cities and has a lot of experience, and if you can get past the guilt for, your daughter falling. By the way, do not donate those monkey bars to a charity, because they'll come with that story. And if God forbid anything, they'll come back to you. I'm sorry that happened, but when kids hurt themselves, there's a lot of lessons learned, and so it's not your fault. By the way, I love working with wood, and I'm also a metal artist. So maybe one day.
Yeah.
I love the idea of mixing metal with wood. I think there's some fun. I like copper, and I use an oxyacetylene torch. But anyway, back to you. Question on the table is, if you had a magic wand, and pretend that nobody important is going to be listening to you except the people impacted, if you will, by this horrible disease and the untreated trauma and the mental health issues. Because, when we talk about a statistic, I'm sorry to take a little more wind out of this, but when we talk about what percentage of people suffer from SUDs, what percentage of the people suffer from mental health issues, I've been around long enough to know that because it's a family issue, it's not just 15% of our population, because studies show that just the addicts and alcoholics who are impaired, the 15%, will negatively impact 7 people every single day. So if you add that number up, we're now talking about almost 85% of the population. So when you talk about the work that you do, and you're working with 100,000 people, assuming only half of them may have chronic issues, whatever that might be defined as, they're going to impact another 3 to 5 people every single day. If not the immediate family, if they're going to work or going to the laundromat or getting on the bus or the trolley, and they're not feeling well, they're going to act out, and it's going to impact people. So take the magic wand, and I know in your head you probably have some really solid ideas, and let's share one or two of them. It's all yours, brother.
No, I really appreciate it. I mean, I think the most significant challenge we face with getting treatment to people who have substance use disorder or addiction issues continues to be that treatment is not seen as, nor framed in the broader public conversation, nor paid for as something normal. It exists on the margins of kind of how healthcare is supposed to work, right? So if we think about it, if we accept the idea that treatment for substance use disorder should be thought about as, as involving to some extent clinical work, as something that sits at the kind of intersection of social drivers of health and sort of clinical phenomena. I think there's probably nothing we could do that would be more significant than making it a more accepted and acceptable part of mainstream healthcare. And when we talk about like $1 billion being in the San Diego County Behavioral Health Services budget, sounds like you'd be able to fix whatever problem you're facing with $1 billion, right? And that's sort of the language we hear from Governor Newsom frequently in referencing the quite a few billions of dollars that that his administration has put towards various kind of components of what I think it's fair to say is the current behavioral health crisis, right? $4 billion for children and youth, and multiple billions, or a $6 billion bond to build treatment infrastructure, right? So there are these few billions that are being thrown around in conversation often, and I think it's important to recognize that those investments are significant. And I'm not saying that because I feel under any political pressure to do that. I mean, those are significant investments that not every state is making, certainly. And Karen,
let me interrupt you for a second, since we're on the money thing. Just as a sidebar, if your budget were to double, let's just say Newsom decides we want to pilot San Diego. San Diego, we're going to give you an additional $1 billion on top of your current budget. Do you think you could create some systemic change within the infrastructure with some of the restrictions and the barriers, or the naysayers, or the politicians? Could you really do something different with twice the budget?
You really can't change the structure of things by pouring more money into it. It in fact doesn't cost anything necessarily to change the structure of things. It takes a certain kind of political will to change the structure of things. It takes a certain kind of, I think, it would take a certain kind of attitudinal change. It would take a certain sort of, approach to the cultural politics that surrounds substance use disorder to make that kind of change. I mean, that the biggest thing I think that could be done would be to systematically drive into every touch point that people have with healthcare a sort of foregrounding of assessments for and responses to addiction and risks thereof at every point. So every time you go visit a primary care physician, which people do pretty consistently, to have that primary care physician actually engage with their patients, not in a heavy-handed, not in a stigmatizing, not in a
Judgmental way.
Not in a judgmental way. It's a good word, but in a way that really is interacting with them and is responsive to what it is that they are bringing to the table as patients. If we could actually create the structures in healthcare that would support that kind of clinical behavior, that would be like revolutionary. Because it is true, when we measure the percentage of patient populations in most primary care settings, right? And I've done, as you noted, I've done this work coast to coast. I did a lot of this work at the New York City public hospital system, where I oversaw behavioral health for a number of years. And I would go around to the primary care practices of the various hospital systems, public hospital systems in New York, and I would ask the chiefs of those services, how many people you suppose, what percentage of your patients do you suppose in this internal medicine clinic have substance use disorder? Oh, none. We don't have that here. We don't have that here. We don't deal with that here, and we don't have it here. I mean, you could talk to me about it, but it's not really relevant because those aren't our patients. What a sort of deeper dive into the diagnostic history of those patients revealed is that it was like often around 20% of their patients not only might be identified as at risk for substance use disorder or likely to benefit from some kind of intervention with a primary care provider, but in fact had been diagnosed with substance use disorder or had indicated in a previous assessment that they were at high risk of substance use disorder, right? And it's just like, so we've even got these administrative health record keeping systems that should enable us to draw the connections, right? Like, man, I'm seeing all these people with very high risk of substance use disorder. I know as a clinician or as a physician, one would suppose these folks would say or think that substance use disorder is very likely underlying the hypertension, the diabetes, the whatever chronic illness. Also, just to say, right, likely array of physical illnesses or injuries that that people present to primary care physicians with. Clinical folks know that SUD is driving those things, right? And then even if you sort of imagine more specialty care settings, right? I mean, oncologists know clinically how significant alcohol use disorder is to the effectiveness of cancer treatment. Just to say, right, like alcohol misuse is devastating to outcomes for cancer treatment. Oncologists should be talking with their patients just off rip about how it is that they use any sort of substance that may be intoxicating. But it doesn't happen, and the reason it doesn't happen is because it's not the system doesn't pay for it to happen. So yeah,
it's interesting over the years, and I've been doing this a long time. I get my information from a variety of resources, and I laugh when I say this because it's so. My primary source of information now is the medical examiner, the coroner. And people shouldn't have to get to the morbidity point in their life.
Yeah.
Families shouldn't have to lose so many loved ones. But we've got to go back over to Fred because since he's the one that pays for all the art behind him, he has the intellect and has.
Well, so sorry, Fred. I just want to put a bow on this point because it's so important to this question.
Please,
Scott, about would another $1 billion help? I mean, money, is a powerful thing, right? It can do lots. But what needs to change about payment cannot be solved simply through a one-time investment. What we need to do is change how the insurance system, and I would say this is true on the private and commercial as well as the public side, but the insurance system needs to really own its responsibility to manage substance use disorder differently. It's got to incentivize primary care physicians to really care about this, to really understand how significant it is, and to prioritize, maybe above all other things, addressing this issue with their patients. And healthcare does what you pay it to do. And I think that, there's no moral high ground here. It does what you pay it to do, very simply. We need to create a system that pays for that to happen.
So, Luke, when I'm on the East Coast, I'm near New York. I'm in Connecticut. What is a couple things like what is the difference between New York and San Diego from your standpoint, from where you worked at both? Was there any big difference, or was one politics better than the other, or anything like that?
That is a great question, Fred. The stigma that I've described, like actual physicians carrying, right? Stigma about about how their patients don't have substance use disorder. I think that's really consistent across the country. And so we'd see that in New York and we'd see that here. I think, New York has New York City specifically, so not speaking to the tri-state area necessarily, but New York City specifically. I worked at the health department and the Bureau of Alcohol and Drug Use, and then in the public hospital system over a 10-year period in New York City. It does have a much more progressive approach to these issues than has prevailed in San Diego County. Right? So San Diego County has done some things historically really beautifully. There have been really strong relationships between, public safety institutions like the Sheriff's Department and stuff like that, and clinical communities here. Those, I think, are things that this community should be proud of. Overarchingly, though, there's simply a politically more conservative approach to these issues in San Diego County than in a place like New York. So you don't see the same, really robust array of, New York, right? New York City's got places like, Daytop, for example, right? Very mutual aid support driven, abstinence oriented, therapeutic community, right? Really long, strong history of therapeutic communities as places to sort of help people manage their addictions in New York City and in New York State. And at the same time that you have those, you've got this really rich set of investments in what has been ideologically the opposite approach in the world of, kind of drug misuse services, and that's syringe exchange programs or syringe service programs, as we call them now, right? So there were when I was working in New York, I oversaw funding to 14 syringe service programs across the city. And a lot of what we worked on doing was saying, you know what, we cannot approach the work that we do. The need is too frigging urgent and profound and massive for us to take an ideologically fractured approach to this. We can't have people who support places like therapeutic communities diminishing the significance of syringe service programs, or people who work in syringe service programs diminishing the significance of therapeutic communities, or any of the other kinds of interventions between them. And I think those, like, that ideological balancing act in New York is a bit more evolved. It's a bit more mature, I think, than here in San Diego. There was a full stop policy prohibition against syringe service programs in unincorporated parts of San Diego dating from mid 90s that was just over the last 3 or 4 years sunsetted here, allowing syringe service programs to operate in the unincorporated parts of our county. There was, for many, many years, there was one very small syringe service program in the entirety of the county that was sitting in the city of San Diego. Now we've really invested in kind of broadening the reach of that sort of service. So the county has stood up a number of syringe service programs that are mobile. And we've done, just in the context of the opioid epidemic, as virtually every community that's paying any attention is doing, we've made massive investments, I think really successfully, in naloxone distribution and other harm reduction oriented.
So Luke, how do you deal with, obviously the numbers aren't going down, it's a growing problem still, yet you're doing what you can do, but yet the numbers aren't coming down. What kind of emotional value is that towards you personally? Do you feel ever like you're not doing enough? Do you feel like
always?
I mean,
but what in this field feels like they're not.
And what's that do for your personal mental health?
Well, and then I have Scott reminding me that I'm not doing it. Also, I would just say, it's of course a struggle, man. I mean, it's not just this, it's not just this population, right? That is, that weighs heavily on me in that respect. It's so much. The prevalence of mood disorder among young people right now, right? Which very often comes with co-occurring, misuse of substances, right? Like anxiety and depression through the roof among, as a father, like that hits very close to home. I feel like we are, we knew that there was going to be a lag between frequency of suicidality and the pandemic, right? We knew that there was going to be a lagging indicator. Everybody during the height of the pandemic was like, what's going on with suicide rates? Everybody, we would hear these outrageous reports of 900% increases in suicides. None of that was true. But now we are, I think, not just as a community, but as a nation, starting to see suicidality and suicide risk as a rising indicator related to the pandemic, because that's how trauma works, right? And we knew that, like, clinically and just epidemiologically, we knew that was, so that shit weighs on me. I think, again, the sort of salve for me in some respects is the important point that this should not be the domain of a marginalized bureaucrat in local government, for Christ's sakes. We should not, as a society, be relying on a contrived bureaucratic structure in local government to be the thing that has primary responsibility for addressing the most prevalent chronic illness that our community faces. Why in God's name isn't that part of and paid for as part of our mainstream regular people healthcare system? I really do feel like, it's why I'm emphasizing this point in this case, but it's also, and Scott, I'm sure, has heard me, yell from other mountaintops about this. This should not be the responsibility of a specialty care system. And we have the best opportunity to address risk further upstream if we get attention on the risks of substance use disorder woven into every facet of healthcare. So like, I'm doing a lot of work with Rady Children's Hospital, for example. Rady Children's Hospital, which is a massive and quite esteemed children's hospital here in San Diego County, has this really beautiful like collaborative care model. They call it transforming mental health, where they do screening for mental wellness in pediatric settings, right? In in general pediatric settings. Most of what they screen for is anxiety and depression. So they use this thing called PHQ-2, and they use this thing called the GAD-7. They measure anxiety and depression. What it's much more challenging to get that kind of institution to do is reliably screen young people for substance use disorder. And it really, it operates on so many different levels, right? It has some to do with the fact that, again, practitioners of general healthcare don't want to think about this issue on some level. It's really true. They don't want to believe that it's as significant as it in fact is. And then it's also, man, they're paid to do a 15-minute visit. How in God's name can primary care practitioners, again, these are the people who have the most consistent touch point with people, how can they meaningfully engage folks in 15 minutes when they got a shit ton of other stuff to be thinking about, right? When they have like treat to target imperatives as a part of their practice, kind of evaluations. They're incentivized to do things other than think about behavioral health. When, again, it's behavioral health that by and large is driving a lot of what's going on in terms of physical health and wellness, right? We know that people with behavioral health conditions 5 times more likely to be hospitalized than people without it, 5 times more likely to show up in an emergency department than without. So yes, I feel a sense of torment about not being able to do enough. And, even with a ginormous budget, it's fair to say. But I also know that the answer isn't and can't be me doing more. The answer has to be other people doing more.
So let me on that conclusion, let me read something here that was given to me. Here it is. I'm quoting this. How can we better create an integrated community of network partners, public or private, to rapidly and effectively help those in need of mental health support and SUD treatment in San Diego? There's a lot of, I'm going to continue. There are many certified, accredited providers, many of whom excel at helping special populations.
Yeah.
But just getting, for example, into Medi-Cal and getting approved, or having a special carve out with the settlement money. This is something you and I've talked about over the years. I mean, if I came to you and said, okay, I want to focus on the veteran population in the Medi-Cal role that you have, could you send a letter out and let us deal with those who maybe want to come in and get an assessment and help them navigate getting access to the VA? I mean, that would be, it's right now, the way I understand it is it's a 1-year process, and then you've got to be approved, and then you have to compete, and then you have to listen to the providers of the money say, well, we've already got an earmark, come back to us in 2 years. So, and then when you describe, when I hear the term pediatric, and then I hear about mental health, and then I know what, because I work with families all the time, that person may have waited 3 months to get in there unless they came in to the emergency department. And I know what the HOT team, homeless outreach team, and what the PERT team is doing now, and they're all screaming about the level of psychosis they're running into when they're seeing people now, where it used to be the primary was SUD, now it's mental health. And that is so opaque. You can't do a 15-minute assessment, even with somebody with handcuffs on who's ready to do whatever is necessary. Because even if they were, as we've talked about with the detox beds, if they're full, where are they going to take them? To the emergency department, who's going to give them something to calm them down, roll them down the hall, and within the requirements of whatever their benefits is, they're going to get them up, move them out, say, see you soon.
Is there a question in there, Scott, that I'm missing?
The question, thank you. The question was, how do we get that carve out? How do we get the community partners? Because you said it, in a position to where they can start helping and maybe peeling off. And I don't even mean creaming the crop. I don't mean, the low hanging fruit. I'm just talking about a specific population. Let's say seniors, let's say single parents, or let's say single adults who are veterans, anywhere in that loop. How can we find a way to fast track that?
Yeah.
So we could, because through our Society of Addiction Professionals, who
Yeah.
you just spoke with, there's probably 20 providers in that room with 50 people that
Yeah.
could start taking clients tomorrow. How do we do that? That's the question. How do we get that going? What can we do to help you?
Well, we have got collectively to work to change the stupidity of a lot of behavioral health policy that rules the day right now. And there is an opportunity right now that I want to flag for you and for listeners to this. And that is, and it's a little counterintuitive, that is this thing that's happening in California that we call Senate Bill 43. Senate Bill 43 is it's like a reform of conservatorship law. So it's a reform of the law that allows like police to put involuntary treatment hold on somebody. And it had been the case in California for the last number of decades that it was not realistic or feasible because of the law to put a hold on somebody with a substance use disorder. Well, now that's changed because of Senate Bill 43. Now, somebody with no mental illness diagnosable, but with a substance use disorder can have a hold put on. They can be detained and transported for involuntary treatment for a substance use disorder. That's not been a thing in California until, well, in San Diego County, we're going live before virtually every other county. It will come true on January 1st of 2025. And one of the things that policy change, and it's a statutory change here. One of the things that is precipitating is a conversation about what the F do we do clinically when these people show up at our emergency departments in greater numbers, and we're supposed to put a hold on them and work with them potentially over not just the next 3 days, but then 14 days and 30 days and 6 months. And like we may put a years long hold on somebody with a substance use disorder. When we know that it very likely won't just be a substance use disorder, right? It'll be comorbid with all kinds of stuff, right? If somebody is like needing that kind of intervention, they have a substance use disorder plus probably a bunch of other stuff. Well, what we need in order to be responsive, we need treatment settings that don't carve substance use disorder and everything else out from one another. We need treatment settings where we can actually clinically address the entirety of the people presenting to us. And I mean, even to Scott's point, right? Like I was up in San Francisco about a month ago visiting social rehab programs up there. Those social rehab programs are kind of long-term housing plus support programs. They get clinical services driven into them. And so it's a model we're sort of looking at expanding down here. And I was asking the folks who run these social rehab programs, again, for mental illness, how do you address substance use disorder in these settings? And they said virtually every person they get is somebody only psychotic because of methamphetamine. And, so now we've got these, we've got diagnoses like substance-induced psychotic disorder. We've also just got clinical presentations where people who are actively intoxicated with methamphetamine are acting batshit crazy, right? They for all intents and purposes, they look like people with a psychotic disorder. It is completely ridiculous to expect clinicians to be able to sort these folks into this person has substance use disorder, that person has mental illness. It's not only unrealistic just as a sorting task, but these diagnostic divisions don't even necessarily, right? It's not like there are neural pathways that these things actually connect. And so, but that's the position clinicians are put in, where we actually have to be sorting people according to these kind of artificial distinctions that, like, trust me, carry a shit ton of stigma with them. And not just sort of like in terms of, sort of cultural stigma, but substance use disorder, and Scott will appreciate this, substance use disorder care and service gets paid way less than payment for people that involves caring for people with mental illness. And so we're putting healthcare providers in positions where they are, and again, you always have to think about money in healthcare as incentivizing something, and money that is supporting this kind of behavioral healthcare is incentivizing clinicians not to acknowledge substance use disorder. Right? We talk so much about we've got to stop the stigma. Well, then let's stop paying for the perpetuation of the stigma, because that's what's happening right now. And I think Senate Bill 43, it's kind of forcing the conversation, because we statutorily, we've got to create these integrated care settings where we really can address substance use disorder and mental health or mental health.
Luke, let me clarify. Let me clarify something, because I was not even going in that direction. What I was talking about is the 100,000 people you're currently serving that are on your, they're getting correspondence. You have an address or an email. I'm talking about that group who may want an option, who might be veterans. I'd like to SB 43 the providers, because it sounds like when you describe that, if we can find a way to mandate that the providers, whether it's the insurance or the bean counters, that say, look, you complain about the money we spend. We've got this funnel to potentially try something here. I mean, Portugal does it, but they've legalized everything, and anybody who wants a bed gets it immediately. And I know what's going on in San Francisco. I hear about the horror stories in their biggest shelter right now, and their overdose deaths are chronic. And LA's got 4-5 times the homeless population San Francisco does. So anyway, we're kind of bending for time here. So
I would just say real quick, Scott, that I was hearing your question, and that the opportunity in SB 43 is to use it to create the kinds of opportunities for the already on the ground providers who right now are not being compensated sufficiently, who don't have opportunities that they should, because they're not connected to hospitals the way they should be, right? I mean, these folks are going to come to crisis stabilization. They're going to come to hospitals. So a lot of the investments that we're making right now with like American Rescue Plan funds, money to prepare for SB 43, are investments in connecting emergency departments to community-based addiction treatment. Because again, I mean, we built this shit at scale also in New York, right? I mean, I had, and they're still there, addiction specializing staff in every emergency department in the public hospital system. We have addiction specializing staff working with all the primary care providers in the public hospital system. We have addiction consult services on all the med surg floors. That the name of the game is about normalizing services for addiction. That's how we address the massive access delta.
Yeah, it sounds, listen, it's completely overwhelming. I hear it every week with Scott, the numbers that we go into and stuff, but we could talk forever. We could talk forever, I'm sure, but we don't have the time, Scott. Not today, at least. But Luke, I want to thank you for coming on. That was interesting. You're a passionate guy. I could tell you brought passion out of Scott there, because I could see when Scott leans up in his seat and his arms start moving. I see a little, I'm happy to see it. It's good for his exercise. He's an elder man at this point, and we need him to stay here, because people like him are what are going to be a part of the change that you're talking about.
Sure.
So I want to thank you. I appreciate you. I hope your daughter feels better.
Thank you.
And we hope we could have you on again sometime, if that's okay.
I'm at your service. I appreciate it.
Excellent. You got any closing remarks, Scott?
Well, at least I'm not hanging my head on my hand like Luke is. I'm jumping back and forth. But Luke, thanks. I know that, every time I give him a hug, he holds me longer and longer. And I really, let me tell you, just from a feedback from the community perspective about you, nobody's criticizing the work you're doing, because nobody wants to do the work that you're doing. And I really applaud you, because, I've seen you in different venues, and you're not, you can be more responsive, but you're working a 34-hour day. So I get it. But I really thank you for what you're doing, because if you're listening to a guy like me who wants to help create systemic change, and I don't care if I do it or someone else does it, and just a footnote. I heard the other day that, they hired those EDs for the navigators for the emergency departments, and the funding just ran out. So now they're gone, which was a great idea to get, people who could help the people with the problems navigate with I'm sure they just ran out of money because of the overdose and the frequent flyers. So I want to slow that down. But I think there's a huge percentage of the homeless population, I'll close with this, that are able-bodied and could go to work. We just have to stop enabling them and give them an opportunity. And we need the worker. So it's a win-win-win. So whenever, when your Senate Bill 43, you need a committee, well, I'll get a hat and I'll put 43 on it so I look like I'm part of. And if I can help you anyway, let me know. But again, thank you for all you do. Thank you for your time today. This is like a vacation for you to be able to talk to people that really want to help you and make it easy and care about human beings. Not that politicians don't, but they sometimes have a different agenda. And I think we need to help them with that. And if we could show them the way, that lead, follow, get out of the way. I'll close with that. Fred, you have any special
so if no one is,
remarks for us?
like I close every week. This is your crisis coach with Scott H. Silverman and Fred Carroll. And if no one has told you they love you today, we love you, and we'll see you again next week. Thank you, Luke, and we'll be back again next week. Be good, everyone.
Wait for him to shut that off, Luke, so you don't lose the download.